Start video. Halo semua, kat rumah tu boleh dengar ke? Good morning. Halo.
Boleh dengar bro.
Oh, thank you bosku. Okay. Here first, then we need to ajak boss first. Boss tak sampai lagi.
Tapi this one yang you nak screen sharing this one?
Oh, ini kita dah tengah screen sharing.
Tak ada.
This is your video. You don't care about your video.
Sekarang ni tengah screen sharing this one juga.
Already screen sharing. So. Slide nampak jelas ke? Ada tim bos kau ni?
Okay. Hi, good morning, everyone. So good morning to our specialists and my fellow colleagues. Today I will be presenting regarding hypertensive emergency in pregnancy. So hypertensive emergency in pregnancy, hypertension in pregnancy, according to Malaysia CPG 2018, hypertensive is defined as a persistent elevation of the systolic BP up to 140 millimeter mercury or greater, and or diastolic BP of 90 or greater, an increase of 15 millimeter mercury and 30 millimeter mercury diastolic and systolic BP levels above the baseline BP respectively is no longer recognized as the hypertension if the absolute value is below 140 over 90. This here is the multiple guidelines of the hypertensive in pregnancy. The latest guideline is from the American College of Obstetrician and Gynecologists in 2019. They divide categories by chronic hypertension, preeclampsia, eclampsia, chronic hypertension with superimposed preeclampsia, gestational hypertension. In American College of Obstetrician and Gynecologists, it's defined by hypertensive, the systolic BP more than 140 or equal to 140 and diastolic BP more than 90, measured at least 4 hours apart. If severe hypertension, the systolic BP more than 160 and diastolic BP more than or equal to 110, measured at 4 hours apart. The type of hypertension, there is chronic hypertension. Chronic hypertension is systolic BP more than 140 and diastolic BP more than or equal to 90 with pre-pregnancy or with pre-pregnancy hypertension or less than 20 weeks gestation. The gestational hypertension, the systolic BP more than equal to 140 and diastolic BP more than equal to 90 at least in 2 occasions, at least 4 hours apart after the 20-week gestation in the woman with previously with normal BP. And there is absence of proteinuria or systemic sign and symptom. If preeclampsia and eclampsia, the systolic BP is more than 140, 90. There is proteinuria with or without sign and symptom and atau ada presentation of sign and symptom or lab abnormalities with no proteinuria. The chronic hypertension with the superimposed preeclampsia in women with previously or has history of hypertension before the pregnancy or before the 20 weeks of gestation. The preeclampsia with severe features, the systolic BP more than 160 or diastolic BP more than 110. And then there is thrombocytopenia less than 10,000 microliter. the impaired liver function that is not accounted by alternative diagnosis or indicated by abnormal elevation of the liver enzyme. Usually it's more than twice of the upper normal unit. There is persistent right upper quadrant of epigastric pain unresponsive to medication. There is a renal insufficiency, pulmonary edema, new onset headache unresponsive to medication, and visual disturbance. This is the comparison of the major hypertensive disorder. Usually we can see the preeclampsia, Hep Syndrome, the gestational hypertension. There is a normotensive before the pregnancy. The hypertensive during pregnancy, usually in all the disorder, there is a hypertension during the pregnancy. The proteinuria usually present in a patient with preeclampsia, Hep syndrome, and the preeclampsia superimposed to chronic hypertension. The thrombocytopenia and or the increased transaminitis, it is variable, depends on the whether preeclampsia is at the severe end of disease. The pathophysiology, usually the pathophysiology of the hypertensive disorder in pregnancy is usually not fully understood. In the pregnancy, the renin-angiotensin hormone usually regulated and the systemic vascular resistance decreased. As a result, this BP initially decreased starting as early as 7 weeks gestation. The maternal blood pressure usually akan increase again in the 3rd trimester. Usually most the accepted theory, they revolve around the abnormal precipitation. So usually we can see it can caused by the multi-factor. Genetics or susceptibility of the environmental or maternal characteristic, immune or inflammatory factor. This can usually in the normal pregnancy, usually the thromboblast begin to invade the myometrium blood vessels by remodeling the maternal spinal artery. They transform the small muscular higher resistant areola to the large caliber with the high capacitance and free blood flow. So the remodeling typically akan start late of 1st trimester and complete by 18 to 20 weeks of gestation. So failure of this process, it leads to the persistence of high resistance spinal artery that impedes the placenta perfusion, thereby leading to state of relative hypoxia. This can result to maternal endothelial cell dysfunction. So the maternal systemic endothelial cell dysfunction manifests in the sign and symptom that relative to maternal vasoconstriction and multi-organ damage. This graph show how to diagnose evaluation of pregnant or postmortem with persistent systolic blood pressure more and equal to 140/90. So we can see if patient more than 20 weeks gestation or less than 6 weeks gestation. Kalau dia more than 20 weeks, if yes, is patient has a significant proteinuria. If ada significant proteinuria, so probable diagnosis is preeclampsia. If there is a following symptom, this following symptom is the feature of the severe features of the preeclampsia, which is systolic BP more than 160, diastolic BP more than 110, ada new onset of cerebral or visual symptom, all the severe persistent right upper quadrant pain, like previously I speak to. And then this one is probably not a sister. If yes, there is a preeclampsia with severe features. If the significant proteinuria is no, and there is no severe feature, so it will be the gestational hypertension. If there is no proteinuria but have severe features, probable diagnosis is preeclampsia with severe features. If patient is less than 20 weeks, the probable diagnosis will be chronic hypertension. So the chronic hypertension with superimposed preeclampsia, which the woman will develop sudden increase of BP that previously will well controlled and need escalation of the antihypertensive medication. There is also new onset of proteinuria or sudden increase in proteinuria. If patient diagnosis with chronic hypertension with superimposed preeclampsia with severe features, then they're going to develop the severe features as well. So for chronic hypertension in pregnancy, so usually this happen is a woman with less than 20 weeks gestation and persists longer to 12 weeks postpartum. Usually the American College of Cardio and the American Heart Association define as elevated blood pressure, systolic blood pressure 120 to 129, and diastolic blood pressure is less than 80. They got stage 1 and stage 2 hypertension. Stage 1 is systolic blood pressure 130 to 139, or diastolic blood pressure 80 to 89. Stage 2 hypertension is systolic blood pressure is more than 140, or diastolic blood pressure more than 90. This woman with stage 1 hypertension may be at increased risk of preeclampsia, gestational diabetes, and small age newborn compared to the woman in a normal blood pressure, as they frequently can be underdiagnosed for this patient. Risk of chronic hypertension in pregnancy. Usually there is maternal and fetal or neonatal. Maternal risk, they can progress to severe hypertension, superimposed preeclampsia, abrasion, cesarean delivery, postpartum hemorrhage, can be stroke, MI, pulmonary death can be cause of death as well. By fetal has fetal growth restriction, small for gestational age infant, preterm delivery, congenital abnormalities, stillbirth, and neonatal death. Pregnancy-induced hypertension or gestational hypertension. Malaysia CPG hypertension in 2018 defined as new onset of hypertension more than 140 over 90 at more than equal to 20 weeks of gestation in the absence of proteinuria or new set of an organ dysfunction. This in Malaysia CPG guideline of hypertension used for antihypertensive drug yang commonly used in pregnancy. Usually the first line we use the metal-dopa. We can give oral 30-50 TDS doubling every 48 hours until the BP control. This is the oldest antihypertensive agent in pregnancy. But currently the latest guideline or the latest studies show labetalol we use alternatively as the first line as well. So we can give oral 100 mg BD doubling up to 48 hours until the BP control. Nifedipine works as the second line. We can give oral 10 mg TDS up to 20 mg TDS when the BP poorly controlled despite maximum metadopa or labetalol. Preeclampsia. Preeclampsia is defined as BP more than 140 over 90 after the 20-week gestation, in additional to either proteinuria or the development on sign and symptom of the end damage known as the severe features. There is hypertension from the graph here. We can see the hypertension more than 140/90. Previously is normotensive. BP need to measure 2 times at least 4 hours apart. Proteinuria, we need to take the 24 hours urine protein. They need more than equal to 300 mg. We can check for protein and creatinine ratio more than 0.3. The urine dipstick more than 1+. more than equal to 1+. There can be multi-system involvement, which is thrombocytopenia, got renal insufficiency, liver dysfunction, pulmonary edema, or cerebral and visual disturbance. The severe feature of preeclampsia. This one, systolic BP more than 160/110 on 2 occasional at 4 hours apart while the patient is on bed rest. The thrombocytopenia less than 10,000. There is impaired liver function or persistent right upper quadrant or epigastric pain, unresponsive to medication, and is not accounted by any differential diagnosis and can cause the impaired liver function. The progressive renal insufficiency, the serum creatinine more than 1.1, pulmonary edema, or the cerebral or the visual disturbance. This will like clinically factor that can increase risk of develop preeclampsia. Typical symptom of preeclampsia, patient will can come with persistent or severe headache, visual abnormalities such as scotomata, which is you can have like blind spot over the eye, photophobia, blurred vision or temporary blindness. Patient can come with upper abdominal or retrosternal or epigastric pain, altered mental status, patient dyspnea and orthopnea. Atypical presentation. So atypical presentation, usually preeclampsia prior to 20 weeks of gestation is usually associated with complete or partial molar pregnancy. Rarely, the characteristic sign and symptom of severe preeclampsia in this pregnancy usually occur in the complete or partial molar pregnancy. But we need to exclude the other disorder with the similar findings, such as the lupus nephritis, thrombotic thrombocytopenia, purpura, the hemolytic uremia syndrome. Another atypical presentation, patient can come with new onset of the exacerbation of symptom more than 2 days for like thunderclap headache. Then severe features of the preeclampsia without the hypertension, isolated hypertension or isolated proteinuria. So if patient come with patient, we receive call pre-hospital care. This one we receive call from MACC said that there is one patient present with preeclampsia or eclampsia. So usually once MACC receive call, they're going to call the EDMO, staff nurse labor room and MA, and then we need to bring either, usually there is the staff nurse labor room will have the Maxa and labetalol. There is a kit they're going to bring as well. But for our side, I think we need to prepare as well, just in case. So usually once we see the patient, so we need to establish and maintain the pattern airways. So usually kalau if patient present with altered mental status, got seizure or comatose, it may be necessary to establish airway manually, or we can use the mechanical device, including the ETT in severe altered mental status. We need to maintain adequate ventilation status, maintain the adequate oxygenation, as the fetus may be experiencing the significant fetal hypoxia due to vasoconstriction of the uterine placenta arteries. And then we need to place the patient in the left lateral recumbent position. This to avoid the supine hypotensive syndrome or further reduce of the placenta perfusion due to the drop of maternal preload and cardiac output. Then we need to provide continuous ECG monitoring, initiate an IV line, and then control the seizure. Usually kalau control the seizure in the pre-hospital care, we can give IM Maxa 5 grams in each buttocks. If not control and we have the IV line, we can start, if we expected the transport time exceed more than 20 minutes of the additional dose, then we can give maintenance infusion 1 to 2 grams per hour. The BP control, we can give IV labetalol or hydralazine, and then we expedite the transport to come here faster. This just example of a hypertensive emergency checklist. So usually if patient hypertensive emergency claim, we need to get the 2 severe BP more than 160 over 110, take 15 minutes to 60 minutes apart. No need to be consecutive, the punya value. We need to may treat within the 15 minutes if clinically indicated. So if patient call for the assistant, and then make sure the side rail is up, ensure the medication appropriate given by the patient histories, administer seizure prophylaxis, which is magnesium sulfate, and then antihypertensive therapy within the 1 hour of persistent severe range. Then place the IV line, draw the preeclampsia labs. The antenatal corticosteroid we can give if less than 30 weeks of gestation. Then we readdress regarding the VTE prophylaxis. We can put in catheter and brain imaging if there is unremitting headaches or neurological symptom. Then we just inform the patient, family, and obstetric team lah. This is the common drugs that used in for the hypertensive drugs in severe hypertension during pregnancy. We have labetalol, hydralazine, and nifedipine. Usually labetalol, we need to cautious regarding patient in asthma because it is a beta blocker in action, so it can cause a bronchospasm. And then for hydralazine, usually this side effect can mimic the worsening preeclampsia as well. Nifedipine, there is a risk of neuromuscular blockage, myocardial depression, and hypotension if combined with magnesium, because it is the calcium channel blocker, the same as magnesium sulfate as well. Okay. So usually the labetalol algorithm, this one is like once you give the labetalol, you can check back over the 2 minutes time. You can repeat the BP after 10 minutes. If not, if still high, you can give another labetalol 40 mg IV. Then repeat the BP in 10 minutes. If still high, you can give another labetalol 80 mg IV for 2 minutes and repeat another 10 minutes. If still high despite the labetalol, you can administer hydralazine 10 mg IV. If still high and that is considered refractory hypertension already, that one I will discuss in next slide. The hydralazine as well, 10 mg over the 2 minutes time and then repeat another 20 hours and then 30 minutes. And then if still high, the hydralazine we can give another 10, repeat another 20 minutes. If still high, we administer labetalol 20. If repeated another 10 minutes, we can consider another labetalol, and then we have to discuss another we need to give any additional hypertensive medication or not. For oral nifedipine, for oral, we can give 10 mg and then repeated 20 minutes. If still high, another 20 mg of nifedipine. If still more than 160 over 110, after the 20 minutes time, we can give another additional round of 20 mg. Then repeat the BP in 20 minutes time, if still more than 160 over 110, we can administer labetalol as well. So in case of the refractory hypertension, we can start the labetalol infusion, nicardipine or the sodium nitroprusside. So nicardipine, it is a dehydrofurin calcium channel blocker. It less negative inotropic effect and is less likely to cause reflex tachycardia. We can give sodium nitroprusside. This is a non-selective direct nitric oxide donor, available in IV infusion because it is 3 minutes duration of action. And then used in last resort because it can cause cyanide toxicity in fetal, which can occur after 24 to 48 hours. So for the laboratory evaluation of the preeclampsia, we can take for the CBC with differential. We can see ada thrombocytopenia, such as for severe disease. We can see hemoconcentration or decrease in hematocrit. Creatinine, if increased, suggests of severe disease, and then ALT, AST, if increased, suggests of severe disease, and then lactate dehydrogenase level, LDH, if elevated, can suggest of microangiopathic hemolysis. Protein in urine more than equal to 1+ in proteinuria. Then 24-hour correction may be done by obstetric team lah. Protein creatinine ratio 0.1 to 0.3 indicated for 24 hours collection of urine protein. And then uric acid level more than equal to 5.5 suggests of superimposed preeclampsia on the chronic hypertension. For the magnesium sulfate is in action to slow the neuromuscular conduction and reduce the CNS irritability. Usually patient with preeclampsia is BP less than, it is usually indicated for severe preeclampsia. So patient with preeclampsia with BP less than 160 but no symptom. So usually we didn't give the magnesium sulfate unless there is sign of symptoms such as headache, altered mental status, blurring of vision, clonus, the right upper quadrant abdominal pain, which is the severe features of the preeclampsia. They have suggestive of pre-monitoring to seizure, then we can consider the magnesium sulfate therapy. So usually in this, okay. So in the magnesium sulfate, the American College of Gynecology state that the decision of the using magnesium sulfate when the severe features are not present should be the decision of the physician, considering the patient value or preference or unique risk-benefit trade-off in every strategy. So magnesium sulfate loading dose, we can give IV 4 to 6 grams over 5 to 10 minutes via the infusion pump. And then magnesium maintenance dose, IV infusion 2 grams over per hour for at least 24 hours. Drugs can be given if these criteria are met. Patella reflex present, and then respiratory rate is not depressed. There is a side effect of magnesium sulfate, flush, nausea, epigastric discomfort, hypotension, flaccid paralysis, and respiratory depression. We need to monitor the magnesium sulfate for toxicity. So monitoring usually hourly, check for respiratory rate and patella reflex. Repeated magnesium 4 to 6 hourly. The magnesium sulfate toxicity we can see by blood pressure can be decreased, pneumonic of Burke, blood pressure decrease, urine output decrease, respiratory rate less than 12, patella reflex absent. The magnesium sulfate toxicity, once we saw there is all the pneumonic of the toxicity that we see previously. So we can stop the infusion during that time. We can see as well, patient can have anuria or oliguria if urine output less than 20 beyond the 2 hours. If oliguric, do the serum magnesium and stop infusion if level more than 3 millimoles. Management of the magnesium sulfate, we can give IV calcium gluconate 10 mils over the 10 minutes. So the normal therapeutic range usually of the magnesium, usually 2 to 3.5. So if we see more than 3.5, then we can stop the magnesium infusion. Anticonvulsion, if there is a recurrent seizure and when the magnesium is contraindication, we can give lorazepam, diazepam, phenytoin, or Keppra. So this study showed that magnesium sulfate is drug of choice in the preeclampsia and eclampsia patient. Besides diazepam and phenytoin lah. In view of magnesium also can provide fetal neuroprotection following the preterm birth with significant reduction in incidence of cerebral palsy. So for preeclampsia, we can give corticosteroid for patient as well. If patient less than patient with severe preeclampsia at 34 weeks or less for the fetal lung maturity. We can give IM Dexa 12 mg 12 hours apart. Fluid resuscitation. So the preeclampsia can cause causing the endothelial damage. So it can cause third spacing of fluid. This create difficult situation where patient came intravascularly depleted, but administrating the fluid will generally rapidly attraversate into the tissue. Then this can cause harm rather than benefit to the patient. Patient can lead to the pulmonary edema, can lead to APO. So usually if patient came with NBM, there is reasonable to support the perfusion, we can give 50 mils of 5% dextrose in a half normal saline. We avoid chasing the oliguria with a large number of weight. So eclampsia defined as a present or of new onset grand mal seizure in women with preeclampsia. It can be also present at late as 1 month postpartum. So usually symptom predicting the impending eclampsia. Patient can come with occipital or frontal headache, got blurring of vision, photophobia, epigastric or right upper quadrant pain, and altered mental status. There is theory of the pathogenesis of the seizure. First one, we can see like hypertension cause the breakdown of the autoregulatory system of the cerebral circulation, lead to hyperperfusion, lead to endothelial dysfunction, can cause vasogenic and cytogenic edema. The second theory, hypertension cause the activation of the autoregulatory system, lead to vasoconstriction of the cerebral vessel, lead to hypoperfusion, localized edema, and then cause endothelial dysfunction, lead to vaso and cytogenic edema. So the eclampsia checklist, we can call for assistance and then make sure the rise up, protect the airways and improve the oxygenation. Patient in the seizure maintaining airway patency and preventing aspiration as the initial priorities. Patient need to be rolled over the left side. This immediate issue untuk prevention of maternal hypoxia or trauma. They are the treatment for the severe hypertension if present, and then prevention of recurrent seizure, evaluation for the prompt delivery. So treatment for eclampsia, we can start with ABCD. Then by seizure control, we can give magnesium sulfate as it is the first drug of choice. If there is persistent, we can give diazepam as well. If with dosage of 10 mg IV over 2 minutes, and we can give infusion 1 mg per minute. So if recurrent convulsion, we repeat. We can give IV magnesium sulfate 2.5 to 5 mg or administer the diazepam 10 mg. If no response or prolonged obtundation after the magnesium sulfate, there is a possibility of ICB, so we need to do the CT brain as well. If patient persisted fitting more than 20 minutes, we can give thiopental, phenytoin or sodium amobarbitol. So for the BP control, we aim the systolic BP 140 to 150, diastolic BP 90 to 100 over the 20 to 30 minutes. We avoid the calcium channel blocker if the magnesium sulfate is used for seizure control, because there can be a synergetic hypotensive effect can be seen during. Drug of choice will be labetalol. There is published evidence suggests that it can benefit the fetus by accelerating the lung maturity. So definitive treatment of the eclampsia is delivery. So for fetal resuscitation, actually we need to stabilize the mother first to help the fetus to recover in the utero from the effect of all the maternal hypoxia, hypercapnia or the uterine tachycystole. If the fetal heart rate tracing does not improve within the 10 to 20 minutes, we can think of the possibility of an occult operation. So the definitive treatment of eclampsia is from delivery. However, after the maternal stabilization, factor can consider in determining the mode of delivery, such as patient gestational age, cervical status, whether patient in labor or fetal condition or position. Then Hep syndrome. Hep syndrome is acronym for the hemolysis, elevated liver enzyme, and low platelet. It is a clinically variant of the preeclampsia. Usually you can see more in multigravida than primigravida. Can occur antepartum up to the 7 days of postpartum. We can see sign and symptom of Hep syndrome. We can see proteinuria, hypertension. Patient can come with right upper quadrant or epigastric pain. Can has nausea and vomiting, headache, visual changes, or jaundice. The pathogenesis is same as the pathogenesis of the hypertensive, is mainly due to the maternal immune tolerance of placentation in the early pregnancy can cause the inflammatory products from placenta into the maternal secretion, cause the systemic maternal inflammation, then can cause the endothelial dysfunction. So this one can cause the RBT to shed, and as they flow through the damaged vessel, this will known as the microangiopathic hemolytic anemia. The lab finding indicated hemolysis, so like normochromic anemia ada high LDH, bilirubin, and low heptoglobin. So from the endothelial dysfunctioning juga can cause the widespread of platelet aggregation and agglutination, reduce the amount of platelet measurable in complete blood count, so we have the low platelet. It can cause the microthrombin in hepatic circulation, cause the damage to the hepatocyte. So for the diagnosis criteria for the lab abnormalities, we can see from CBC or test of peripheral smear, we can see of cystocyte. And then the platelet count usually is less than 10,000. If less than 150,000, we can suspicious of the Hep syndrome as well. Liver function test usually elevated, but below usually what we can see from the viral hepatitis, which is less than 500. The renal function test usually normal or elevated urea natron and creatinine level. Coagulation profile usually abnormal. LDH will be increased, suspicious of hemolytic anemia. Total bilirubin more than 1.2 milligram. Complication of Hep syndrome patient can develop DIBC, abrasion placenta, severe postpartum hemorrhage, rupture of subcapsular liver hematoma, can cause intracranial hemorrhage or infarction, and pulmonary edema or acute renal failure. For the BP control treatment, we can give so BP control of the Hep treatment, we can give IV magnesium sulfate. The BP control, we can give IV labetalol or hydrazine. Definitive treatment need to be delivery. If more than 34 weeks, delivery after the maternal stabilization. If less than 34 weeks, we can give corticosteroid for fetal lung development. Delivery recommend after 48 hours of evaluation and stabilization. For the complication of subcapsular liver hematoma, we suspected in any patient with preeclampsia or Hep Syndrome with right upper cardiac pain, usually diagnosed with ultrasound. Treatment, we optimize of coagulation factor, large bore IV access, emergent surgery or angiographic embolism. So we need to call for IR for the angiographic embolism to treat the hepatic rupture. And potentially can even go to liver transplant as well. So for the APO, usually APO due to the multifactorial fluid overload, they can cause decreased plasma oxygenate pressure, increase capillary permeability, increase pulmonary capillaries hydrostatic pressure due to the arterial vasospasm, cause increase in cardiac overload. And then we can give supplement oxygenation, fluid restriction, diuresis if fluid overload. DIVC. This is a scoring system for diagnosis of DIC in a pregnant patient, having developed but usually not widely used. For patient in the IVC, we can active MTP or RTP protocol. Indication for the red blood transfusion if HB less than 7, or patient have ecchymosis, severe hematuria or we suspected of abrasion placenta. Indication of platelet transfusion if patient is actually actively bleeding with thrombocytopenia if platelet then less than 20,000. For patient with AKI, treatment usually just supportive. Dialysis if patient usually based on usual criteria, especially for if oliguric present.
For the question part, we pause a bit. We have another top-up presentation on a short discussion. After that, then we will have our Q&A session. Oh, just I haven't. No, this one. Presentation.
Can we continue with the top-up CME? Okay, today I will talk more details about the Maxa as a seizure prophylaxis. Okay, how to go next? Okay, so actually Maxa, we not common use Maxa as an anti-epileptic in other type of the seizure, but we use more preferable for eclampsia and also severe PE lah. The mechanisms of the anticonvulsant effects is not well understood, but because based on our eclampsia pathophysiology, like just now what Miza mentioned, we have vasoconstriction and also we have cerebral edema, so that promotes the seizure. So the mechanism of anticonvulsant effect of Maxa actually they aim for these three. So this is what I take from the up to date. There are three hypotheses for this. The first one, they act as a calcium channel blocker. They're causing cerebral vasodilation. So they reduce cerebral barotrauma. The second one, they protect blood so they decrease the cerebral edema. The third one, they also act as an NMDA antagonist that increase the seizure threshold in the eclampsia patient. So why actually we use Maxa instead of other anticonvulsant in the first place? Because all these are based on evidence-based. In the meta-analysis of the randomized trials, they include PE and eclampsia patient. They found that actually Maxa, as compared to phenytoin and diazepam, they bring more effective to prevent first seizure and also recurrent seizure in eclampsia and also PE patient. And they also reduce maternal death. And all trials state that actually they help to reduce maternal death, but there's no change in the neonatal death. And the advantages, of course, Maxa low cost, very easy to administer, which we don't need any cardiac monitor, and the lack of sedation, in which these two might will need in the benzodiazepine if you give benzodiazepine. So other than they bring the maternal advantage, they also bring neonatal advantage. They help to decrease the risk of cerebral palsy in the neonates. So there's a trial. The name is Collaborative Eclampsia Trial. This is a multi-center international trial done in 1995. They involve around 1,700 women. So they compare Maxa versus diazepam and Maxa versus phenytoin. So they found that more than half of the patients treated with Maxa, they have lower risk of the recurrent seizure as compared with the diazepam and also phenytoin. And of course, like what I mentioned, they reduce maternal mortality. Other than that, they also reduce pneumonia, ventilation, and also mother will be less admitted to ICU and kids will be less admitted to NICU. There's another trial, they call it Magpie Trial. This Magpie Trial, they actually prove the efficacy of the Maxa used in PE patients. They involve around 10,000 women. In these 10,000 women, they are all PE patients. They fulfill the criteria. They got BP more than 140/90, and they have proteinuria at least 1+. Of course, the people treated with Maxa, more side effects, but they show that the patient treated with Maxa, they have 58% lower risk of eclampsia compared with the placebo. And maternal mortality reduced by half, placenta abrasio reduced by 30%. And all trials state that neonatal mortality actually no much difference. So when we have to give the Maxa, not all patients come in hypertension in pregnancy, we have to give Maxa. We only give Maxa in two conditions. First is PE with severe features, and the second is eclampsia. So based on this table I get from the ACOG guideline, these are the severe features of the PE lah. I will not repeat again this one, but then always remember, if the patient like PSC call, you attend the case, you bring Maxa, go. When the patient having like BP more than 160, 110, and the patient having some visual symptom, so already fulfill the severe feature for preeclampsia. So you can stretch out the iron Maxa, then bring that. Then of course, the second indication is eclampsia when the patient fit lah. So is there any role if the PE without severe feature, then we give Maxa? Actually, there's two randomized trials. They give placebo or Maxa for the PE without severe feature patient. So they found actually no cases of eclampsia among women given placebo too. So means that you give placebo or Maxa in this PE without severe feature also no difference. So the clinical decision whether we want to give is depends on the physician, the patient value preferences, and also the risk benefit. So how you want to administer? We know the dose IV like 4 to 6 grams, but how about dilution? Sometimes staff nurse will ask you how to dilute, or sometimes staff nurse don't have, then you want to dilute yourself. So this is the Maxa ampoule. Total, we got two routes. One is IM and second one is IV. So if you have IV line, better you give IM or IV. Okay. If you got IV line, better you give IV or IM. I mean in the resus lah. Sorry, my question. Okay. Based on the guideline, if you have IV line, it's better you give IV because IM they bring higher magnesium toxicity and also more painful. So you give IM only at the PSC level and when you don't have any IV lines. So IM total we give 10 grams, 5 grams each buttock. So one ampoule Maxa we have 2.47 grams, which is equivalent to 5 mils. So we withdraw 2 ampoules, which is 5 grams, 10 mils of Maxa plus 1 mil of LA. And always remember, if you want to withdraw the LA, you withdraw at the last. So when you inject the LA first, then only inject the Maxa. So we will reduce the pain. And so you got two strings of 5 grams, then 5 grams into each buttock. Then for the IV, loading and maintenance, Loading usually is 4 to 6 grams. So if you want to use 4 grams, you withdraw around 8 mils, which is equivalent to 4 gram Maxa, plus 12 mils normal saline, make it into a 20 mil syringe. So infuse this over 15 to 20 minutes. For the maintenance, usually 1 to 2 grams. If you want 1 gram, withdraw 4 ampoules, which is 10 gram, 20 mils of Maxa, plus 30 mils normal saline, make it into a 15 mil syringe. So in this 15 mil syringe, you contain 10 gram of Maxa. So 1 gram equals to 5 mils. So you infuse 5 mils per hour is equals to 1 gram per hour for 24 hours after delivery or after the last seizure. See whichever comes first lah. So this is table I get from the EM doc. Like what I mentioned, IV loading 4 to 6, maintenance 2 gram. IM 5 gram each part, maintenance 5 gram every 4 hours. And if the patient with renal insufficiency, their loading dose is the same, 4 to 6 gram, 15 to 20 minutes. But the maintenance dose have to cut into half, 1 gram, because our Maxa is excreted by our kidney. And if patient, you give Maxa already, but you come in, patient have another fitting after your episode. Actually, you can give another second bolus of Maxa, but you give half dose. You give only 2 gram over 3 to 5 minutes. But after you give 2 bolus of Maxa, patient still fitting. Then you have to think of other diagnosis. Maybe this patient is not eclampsia. Maybe it's some ICB or aneurysm bleed, something like that. Because based on up to date, they found out the patient that refractory to the second Maxa, sometimes their CT brain have no abnormal finding. So in this kind of cases, you may have to discuss with the EP or primary team to proceed on any CT brain or not. So if they're refractory to the second Maxa, then you try other medication, lorazepam, diazepam, and consider for phenytoin also. So when you start Maxa already, you have to assess them every 1 to 2 hours based on this BERT. BP low, urine output low, RR less than 12, and patella reflex absent. So you only continue your maintenance dose when these all absent. And not every patient we need to check the magnesium level, only when the patient have renal insufficiency and the present some sign and symptom of magnesium toxicity. If not, actually, we don't need to check any magnesium level. So this is a table based on how many magnesium, their toxicity, and their effect. And always remember, the first symptom is loss of patella reflex. So always pay attention to that. Yeah, that's all. Thank you.
So any question from my bosses or my fellow colleagues?
I think the slide for the preparation slide was quite good. Sometimes you want to
have a quick look.
Sometimes when you want, don't have. Sometimes when you want, they don't have.
sometimes if I put the pre-fiber so you know the slide is quite good and she gives out the max, so you know what then how much I think that is yeah, quite good.
Macam cakap tadi, kita identify sebenarnya HIV kan, but that's only if we have also monitoring. So I want to talk about eating resistant something in the often. So let's say you are a patient dengan ada genetic seizure, and patient ada what would be your choice? IV or
IM.
Sebab IV loading pun around
15 to 20.
Susah nak time kan 15 minit. So ENT, PHP setting tak boleh bagi ahli. So sebab biasa saya sebenarnya like itu, it sometimes to what? So kalau feel ada fikir itu semua. Lagi dapat macam magnesium level increase. Actually, what's the first thing that you can do? No.
Golong cucu.
I think the presentation is quite good. So just to you yang boleh top up lah, beli titik the supplementary effect. Dan yang buat the supplementary presentation itu, can you guys compare dengan yang first presenter kalau kita tak nak melakukan presentation, and then at the end kita akan ada comparative information. Ini adalah some information that is from
16.
So one coding kita perlu buat tu, and then make sure you guys have information. Check out lah yang telah koordinasi bila according to CPD, kalau BP itu more than 40, itu you can take your time, allow patient to rest, and then we have to follow lah. Tapi kalau BP itu more than 150, usually kita tak akan wait until 4 hours kalau kita nak take. Usually kita akan take the patient from the period of time, within 15 minutes atau 30 minutes, and then kita take blood pressure. Okay. Because what kita cakap, kalau kita tak nak this patient, and we don't want to take this patient fully. So by the time kita nak follow the BP after BP, we should up with the patient akan with the patient. Okay. So kalau more than 160, over 110, cut down the observation time. Okay, so that we can take the patient faster. Kita cakap pasal treatment ni, tapi apa kita punya endpoint? Until what we want to reach. Okay. So kalau ada CPD kita ada cakap ke? I don't think so. CPD tak ada cakap. SUVT, bla bla bla. Tapi yang I baca untuk discussing the main one is you nak kait dengan diastole. Diastole is probably you nak give less than 85, around 85, and then avoid it to become lower than 80. Okay, punya systole itu you can macam allow up to 100. Tapi the main one is diastole. Okay, but sometimes when you have jadi kita pun tak boleh tengok lagi ya, tapi punya diastole dah tak tahu. And then kalau macam Maxa di Eeclampsia, the one is clear cut. No one can argue kalau kita is there. Control severe Preeclampsia. The decision for Maxa, I think we better discuss the way it's atas. Kita punya specialist tu ada dia punya own preference. So if we can, because tadi macam kita punya ni, kalau predictive management kan, we can get into from the other party. That one will be better. Okay. So if Eeclampsia, then we should severe Preeclampsia, and then we can discuss. AC level. Kalau Eeclampsia ya, kalau ada echo company mesti ada isu. Kalau yang Preeclampsia itu juga betul betul just monitor the patient. Okay. And then siapa yang bagi respon untuk kita punya drug tadi lah. Yang tak sana baru nak baca saya nak periksa. Berapa ringgit lah. Kalau tak sana baru nak baca je. Coba kita baca berapa ringgit.
Kalau baca tak boleh cucuk nanti ke mana?
Batuk tak boleh cucuk. Kenapa tak boleh cucuk, bos? Ada batuk. Hai. Nak tanya bos, kalau let's say kita respon case PHC, patient Eeclampsia tapi dah habis fit dah. Already habis fitting, patient drowsy, kita letak hypermask, kita bagikan. Okay. Dengan ada previously pernah encounter satu case yang dilema sebab dia patient pregnancy memang ada their pressure a bit high lah upon the ambulance call. PT is like 150 over 90 like that. And then patient known case of epilepsy. So masa tu kalau dia fit tu first treatment tu max up ke atau diazepam? Pregnant more than 20 already term.
Because you don't know which one comes first.
Yeah.
But then you know you make something is much more protective to the mother and to the baby as compared to your diazepam. Okay.
So remember here, treatment
Any more want to top up? Oh, Abbas.
and the team response to complication so masa langkah respon itu siapa yang ikut?
There is a one MO resus and one staff nurse from labor room. This is one JM from labor room, and then sometimes on and off got a ONG MO. But this one not promising lah. Usually it's only our own MO and one labor room with staff nurse. So if let's say patient suddenly go in labor, the JM can handle the baby everything lah, and then the MO can focus on the mother. But usually if our floor is permissible, usually we send 2 MO lah for such cases. If not mistaken, it's Labetalo and Maxa. From
So dia mana dia orang buat sampai dia kecil. Most of the time, dia orang dah figure out things yang kita boleh replicate. We get Eeclampsia
I think every month.
Because the things that you see rarely, the thing didn't come to your mind immediately bila kita practice. Benda yang kita dalam kita tengok, kita mana ada semacam itu. Tapi benda yang dalam kita tengok, kadang-kadang itu random for information. Internet lain tu. And if you have something like that, you macam toxicology dia ada science. Okay. So kalau Eeclampsia kita buat dia macam tu, then if you don't put the drugs inside, like when I have it on the floor, it's not a suggestion, it is a must. Otherwise, I do a cari-cari application if you find it. And then the other thing is Eeclampsia, kita manage the range. So apa dia alert system dia?
Basically, when the ambulance already depart, we already call the ONG team to inform that there is a case that we are responding. How long is the ETA? And then usually the ONG MO already will stand by and resusc. Yeah. So if let's say patient coming still persistent fitting, they can have an immediate decision to proceed with seizure or intubate everything.
So maybe the ambulance will
Yes. Yeah. Here. Resusc. Really resusc terus. Sorry? Oh, yang datang sendiri. If dia memang the fit kat triage, is resusc. We will call immediately. Meaning when simultaneously when patient is transferred to resusc, we tengah stabilize the airway, the intravenous access, we will call O&B team simultaneously. Because they don't need to know very detailed. We just like say patient, term patient, suspect hitting, Eeclampsia, then they will come already. It's very fast. Kita tak. I think previously pernah discuss kan, masa tu sebelum ni ada macam code untuk activate, but then due to COVID punya issue dan stand down. Pizza. Ya betul. Sebelum ni tapi saya tak tahu dia punya sistem tu dah activate balik ke tak lah, sebab tak kan. Any other more top up and question? No, code break lah. Thank you, boss.
Patient is not eating lah. Not eating, right? If already we can give you other medication, especially
Okay. Any more to question or want to add on any information or any announcement? Okay, kalau tak ada, then our CME is up to here. We got makanan, boleh jemput makan, mi pun yang sedap dengan ayam. Okay.